Sleep apnea, it is a cessation of breathing for a few seconds, and depending upon for how many seconds it occurs, it can be partially or complete. So let me explain it in a very simple way. That what happens is when normally we breathe, air enters through a narrow passage, which is our airway, and it is made up of muscles, so which are in active form during breathing. So when patient is awake, and during sleep, what happens is these airway muscles goes to the relaxed position. So when patient is sleeping in supine position, sometimes there is relaxation of these muscles, which causes compression of the airway. So it can be either partial or complete collapse of the airway, and it depends on for how many seconds it occurs, and we call it as apnea. So apnea is cessation of breathing for at least 10 seconds. And what happens next is when air is not going through the passage, then there will be fall in oxygen to the body and to the lungs, and then a signal will be sent to the brain that you need to be awake. There is no oxygen supply to the brain. So patient will become awake, and he might get awake multiple times at night, and he may or may not be aware of this, that I'm getting up again and again in the night. So this is a very important feature of sleep apnea, that sometimes the patient's partner can tell us that he's getting choking again at night, and he's getting again and again at night. So this is important in the history taking also. So apnea is complete stoppage of breathing for at least 10 seconds. And there is also a term which is hypoapnea. In hypoapnea, there is a decrease in respiratory decrement in airflow, and which is less than 10 seconds. Sleep apnea is of three types. The first and most common type is obstructive, and second one is central, and third one is mixed, which is a combination of these two. Obstructive sleep apnea is the most common type of sleep apnea, which we see in our patients usually. The most it occurs in the obese patients. So, in what happens in this obstructive sleep apnea is the air. Then, when patient is lying on the supine or patient is sleeping, the air muscles of airway get relaxed, and in obese patients there is a amount of fat deposition is more at the neck area and all over the body. So when patient is lying on the supine, his respiratory airway is getting collapsed. That is why it is causing obstruction, and the patient is getting apneas at night. But other causes of obstruction can be tonsillar hypertrophy, adenoid hypertrophy, deviated nasal septum, elongation of soft palate. So these are the structures which comes in the airway, and they also can cause the obstruction to our airways. The second one is central. The central sleep apnea is most commonly seen in the patients. Those are having a congestive heart failure, and patients who are having neurocognitive dysfunctions like neurological deficits. Those are already having neurological deficits, and the patient is having any on sedation, or patients are those are IV drug users or addicts. They can have central sleep apnea. And what happens in this central sleep apnea is there is a disruption of regulation from brain to lungs. That is why the lungs stop breathing. So it can be seen in these patients like CHF and in with patients with neurological deficits. And in what happens in mixed sleep apnea is it is a combination of both, when there is a no airflow and no respiratory effort. But events in this mixed sleep apnea, initially they can appear central in origin, and there can be obstructive in later on. First, the foremost symptom the patient will complain is, and he is getting up at night again and again. So it can present with the choking during night, or he may become aware of the awakening happening multiple times. So even the partner can tell us that the my husband or my wife is getting up at night again and again, and he I have noticed that he was choking during night. So these are the most important complaints that the patient and the patient partner can tell us. The other next symptom is frequent urination at night. Other are excessive daytime sleepiness. Patient is sitting in a lounge or in a waiting area, and patient maybe doze off there. Other are confusion. The patient might complain that I remain confused all the day, and I am not able to concentrate on my daily activities properly. And the patient can also complain that while driving I fall asleep, and all these are the symptoms that patient can complain to us. Most common risk factor is obesity, like patients who are having a body mass index of more than 30 kilogram per meter square. They are most on the risk of obstructive developing obstructive sleep apnea. And the second one is anatomical disturbances like DNS, tonsillar hypertrophy, adenoid hypertrophy. Third one is the patient who is having a narrowing of hard palate, and other comorbidities like hypothyroid, people with PCOS, and other hormonal disturbances. Those are comprising towards the weight gain. They are at the risk of developing obstructive sleep apnea. The patients who are diabetic and ischemic heart diseases, sleep apnea are also quite more common in those patients. First of all, you should consult your physician, your chest physician, or ENT consultant, and you can consult any one out of them. So, first of all, we have to rule out the other causes of obstruction in chest. The patients who are having allergic rhinitis, allergic sinusitis, we need to treat these causes first, and then we have to evaluate the proper obstructive sleep apnea. So, how it is diagnosed? The polysomnography, it is a gold standard investigation for to diagnose obstructive sleep apnea. What we do in polysomnography is it record multiple parameters while the patient is sleeping. These parameters are EEG, electroencephalogram, electrooculogram, electromyogram, and other oronasal thermistor and nasal pressure sensors to indicate respiratory airflow, chest and waistbands to measure the respiratory efforts, and arterial oxygen saturation monitoring. We have four levels of polysomnography. In level 1, polysomnography is a proper sleep, it is done in a proper sleep lab, and these are all are the parameters those we measure during polysomnography. And the level type 2, which is level 2 polysomnography, it is a complete unattended home study. Parameters we measured are the same, but it is only done at the patient's home. In level 3 polysomnography, it includes measurement of airflow, respiratory effort, pulse, and sleep position, and it includes ECG, heart rate, saturation. In level 4 polysomnography, only pulse rate and oximetry is measured. And what we do in sleep studies, we monitor the patient for whole night, and next day report is made. Then we calculate apneas and hypoapneas in a graphical representation. So apnea hypoapnea index needs to be calculated, which is apnea plus hypoapnea divided by the number of hours of sleep we have monitored. This is a polysomnography, and along with polysomnography, we also do the titration sleep study. In titration of sleep study, the patient is monitored for the entire night, but positive pressure positive pressure mask is applied to the patient's face. So it measures the reading of the pressure with which the patient needs to be treated. Along with polysomnography, we also do the titration sleep study. Patient is sleeping for the entire night, but we apply a mask over the patient's face, which applies the positive pressure to the patient to keep the airways open. So with that, we'll get to know the idea, and we'll get to know the pressure settings, which helps in the treatment of the patient. That this much is the pressure needs to be keep his airways open. The complications which can occur if we left this sleep apnea untreated are: first is neurocognitive consequences. The patient will have increased daytime sleepiness, and there will be sleep fragmentation. So patient will not be able to sleep properly. So if patient is not able to sleep properly, then he'll not be able to concentrate on his daily activities, and he might get sleep sitting on a chair and while driving. So if patient will fall asleep during driving, then there will be more chances of motor vehicle crashes. And the next is if patient is having a obstructive sleep apnea, he is more at the risk of developing cardiac disorders. Half of the patients with OSA have coexistent hypertension, and about 30 to 40% patients of hypertension have OSA. Other OSA related complications are the patient can have a memory disturbance, and he will be less vigilant in everything he does. we need to evaluate the reason for obstruction. So if patient is having any tongue abnormality or any ENT cause like any de-innervated nasal septum or tonsillar hypertrophy, so surgery can be done in those cases. So it needs to be treated. And if patient's cause for obstructive sleep apnea is obesity, then first is lifestyle modification, second is weight reduction. He can have gymming or any other activities, cardio. And if patient continues to reduce weight, apnea hypopnea index will eventually decrease. There are three types of machines that patient can be used: CPAP machines, BiPAP machines. In CPAP, we apply a continuous positive airway pressure to the patient for the whole night. And in BiPAP, we have two levels: bilevel airway positive pressure. We give two pressures to the patient, that is IPAP and EPAP. So we'll treat the patient according to his sleep study report and according to the patient's preference. The first is we'll advise the patient to sleep on the lateral position, in lateral side. What happens is when patient is in the supine position, the airway will collapse more. So we'll advise the patient to keep lying down on the at night on a lateral position. So there is a one method that we can use is we can make a pocket in the back of the patient in which he'll kept a ball. Whenever he is going to the supine position, he will be awake because he will not be comfortable in that position. So this will help that the patient will lie on the lateral position. The next is we call this method as a tennis ball technique. And the second is weight reduction. The patient needs to reduce his weight to get rid of this obstructive sleep apnea. The next is to treat the other comorbidities like diabetes, hypertension, ischemic heart disease, congestive heart failure. That diuretics need to be given for that. And avoid alcohol, caffeine. Most important is smoking. And sedation will also contribute to this sleep apnea. So all these methods can prevent sleep apnea.